Good afternoon, everyone. And I would like to begin my talk by thanking the organizers for giving me this opportunity. As the stage has been rightly set about the HER2 positive breast cancers, my previous two speakers have spoken in detail about it. I would continue on the same topic and we will discuss in short about how the journey for HER2 positive breast cancer patient is ongoing, a transformation towards better patient care. So we have discussed this in the previous two lectures, the Perjeta Herceptin combination, THP, that is now the standard of care in neoadjuvant, adjuvant, as well as metastatic breast cancer. The pivotal study in the neoadjuvant setting was the Neosphere trial, where the addition of pertuzumab to Herceptin and chemo, it improved the PCR rates from 31 to 49%. And there were additional supporting studies like the Trifina, Bernice, and Peony study. In the adjuvant setting, the early breast cancer at high risk of recurrence affinity trial was the pivotal study where P plus H plus chemo, it reduced the risk of recurrence or death by 23%. And in patients with node positive breast cancer, chemo plus P plus H, it reduced the risk of recurrence and death by 28%. The metastatic breast cancer Cleopatra trial, it has been discussed in detail in the previous two lectures as well. It has shown a median OS benefit of 56.5 months. So Perjeta, Herceptin, chemo, now it is the approved and recognized by international guidelines as the standard of care in HER2 positive breast cancer, be it neoadjuvant, adjuvant, or metastatic setting. So any HER2 positive early breast cancer, pertuzumab, trastuzumab, and chemotherapy is the neoadjuvant standard of care and adjuvant standard of care in patients without residual disease. This slide we have seen in the previous lecture as well. So, but what is the disadvantage of this? What the patient faces is that there are two long infusions of pertuzumab infused over 30 to 60 minutes, which is to be followed by a observation period. Trastuzumab is also infused over 30 to 60 minutes. So, and of course, there is a preparation time for the IV formulation. We have to, these, as we can see, the course are 16, 18 cycles. So there's a prolonged indwelling venous catheter. So establishing and maintaining an IV access for this long is a challenge. So FESCO is the first formulation to combine two MABs, that is pertuzumab and trastuzumab, in a single vial for subcutaneous injection. It contains the same antibodies as approved for IV pertuzumab and trastuzumab, but as a subcutaneous route of administration. It is formulated with recombinant human hyaluronidase to allow a subcutaneous administration, because the volume is around 15 ml in the loading setting and 10 ml for maintenance dose. It is a ready-to-mix fixed dose formulation. So the time of preparation is also reduced. So mechanism of action of pertuzumab and trastuzumab fixed dose combination in the subcutaneous use is the hyaluronidase acts as the endoglycase to increase the dispersion and absorption, while the drug, as they are designed to work as dual HER2 blockage pertuzumab, and the mechanism of action is of course the same. So the impact of having a human recombinant hyaluronidase is so that the larger volume of fluid can be given and there is no bleph formation or such a thing. We can see in this picture, like if we give without recombinant human, without hyaluronidase, this is how it appears. While immediately after infusion, if we have a recombinant hyaluronidase, this is the picture. So the Cosmesis effect is also there. So now the next question that comes to our mind is, are the pharmacokinetics and efficacy the same? Is it safe? So of course, FESCO has underwent rigorous clinical development program from phase 1 study to deciding the dose, loading dose, maintenance dose, and the efficacy and safety studies are still ongoing, but are showing very promising results. So the phase 1 study, which had various doses, various cohorts, where the doses were titrated, and hence we came with a low with the doses which were safe and effective. And then the phase 3 non-inferiority study was conducted, where it was compared with this, and followed by which is efficacy as well as the safety has been established with these studies. The pharmacokinetics parameters are also important for understanding, and the pharmacokinetic endpoint of this study, they have shown bioequivalence. Giving both the drugs, they have been compared through IV as well as subcutaneous route, and they have shown equivalent pharmacokinetics. So it has been established through through the Federica study that the serum levels are similar, and so the pharmacokinetics is absolutely comparable. And so they're identical response rates with both the drugs. So the safety profile of both is comparable. The adverse events are same. So the rate of treatment discontinuations are also similar in both the arms. So we give it IV or subcutaneous, the side effect profile is absolutely the same. The common adverse effects were consistent with the IV formulation. There were no new safety signals seen, no new adverse events observed. So the incidence of adverse events, cardiac dysfunction, hypersensitivity, they were all comparable, as we can see. There's no meaningful difference in cardiac safety. So what comes to our mind is a fixed dose combination and comparing an IV formulation which is based on weight, but the studies have compared it thoroughly and there is no difference in the cardiac safety as well. So these studies have established that the subcutaneous Phesgo is non-inferior to IV formulation. The efficacy and safety both are comparable. The pharmacokinetics is similar. The results are similar. So what do you think? What would our patients prefer? An IV formulation, which is 90 minutes infusion, or a subcutaneous injection of 10 minutes duration? So even to assess that, a study was conducted and patients were allowed to cross over after 3 cycles of IV or 3 cycles of subcutaneous administration. And what was seen is very much expected, that most of the patient preferred a subcutaneous administration. And the main reason was less time in clinic. Except for we doctors, nobody prefers to stay in clinic for long. So most of the patients are more comfortable with the subcutaneous administration. So, and they were either very satisfied or satisfied with this administration. So the majority of patients of healthcare professional also felt that it is a better alternative because the drug preparation duration is decreased, the time in the treatment room is decreased. So were there, of course, it was compared, were there any new adverse events or any new safety signals with the subcutaneous formulation, and there were none observed. So main reason why patients and clinicians now prefer a subcutaneous preparation is less time in clinic and more comfortable during administration. So what are the practical considerations for us and any challenges in the real world? So how it is administered? The patient is preferably in a reclining chair or bed. The thigh area is to be exposed, and we have to position the syringe at 30 degrees like this. We have to raise a bleb, create a screen fold, and then at a 30 degree, the injection is given. So, and it is to be administered slowly for around 8 to 10 minutes, and then observation period of 30 minutes for the loading dose and 15 minutes for the maintenance dose. So the time of administration and the observation, both are decreased with this. So best practices, we can put a separate area just because it is the thigh area. So preferably a daycare where the outpatient setting, where a separate room where the patient can have a little privacy. We can expose, administer the drug and observe the patient for the next 10 minutes or so. So what could Phesgo mean for patients and us healthcare professions? It is like a boon because it has a shorter administration time. 5 to 8 minutes, and of shorter observation period of 15 to 30 minutes. It has a less invasive administration. While with IV preparation, we have to keep our indwelling catheters for 18 cycles. Here, a subcutaneous administration is, and there is no need for IV route. So the risk of infection definitely comes down. So, and of course, the risk of IV drug, pain, bruising, every time a needle, so all this is decreased. Fixed dose formulation may reduce risk of dosing error. So of course, as we know, during the course of chemotherapy, patients undergo changes in weight. So the dose needs to be recalculated if there's a more than 10% change in weight. But with the fixed dose formulation, the risk of any error of dosing is reduced. The drug wastage is reduced. Reduced time required for drug preparation and administration is there. And since there are no safety signals, it is definitely safe to opt for FESCO over IV formulations. So overall summary is the first formulation. This is the first formulation which combines two maps in one vial. And it has a faster and less invasive method of administration. And the serum concentrations have been compared and they are comparable to IV formulation. So we can even switch our patients. And the pathological, the response rates are identical. So and it does not impact by BMI. So it is definitely a very good alternative to improve the quality of life of our patients who are HER2 positive. Thank you. Any questions?
Thank you, ma'am.